Okay. So I said this last week, but just again to reorient you, this is our last topic before the exam. So we covered all of Monday. We finished the autism section, and now we're talking about schizophrenia. And we'll talk a little bit why these two things are kind of lumped into the same chapter or the same topic week, and why your textbook does it. So we'll cover that. And then just a reminder, depending on how things go today, we may or may not get to this exam review. And so we'll keep Friday as our carryover day. And remember, attendance is not mandatory. You don't have to come. Yeah, up to you. And then I'll remind you again on Friday, but reminder once more that the exam is on Monday and it opens at 12 a.m. Monday and it closes at 11:59. Okay, so skipping over all this stuff. We did our case study. Okay, and then we ended here. Before I start, any questions about what we talked about on Monday? Okay, so schizophrenia is what we're covering. Oh yeah, go ahead.
I'm sorry, I don't mean to. I do have a question.
Yes.
Last week you talked about the regression of potty training being age appropriate. What if a person was to say, my child has regressed on multiple um, developmental things? Does that have more significance to it?
Yeah, so I'm trying to remember in what context. So okay, so last week we were talking about Monday. We were talking about the three different courses of onset, and it could be like you notice there's pretty slow progress, or there's that second option where they seem to be developing typically, and then they're starting to be a regression. And an example could be potty training. So yes, I would say think about like all the aspects of developmental functioning. And so if we're expecting that like potty training is going to be pretty hard and we give or take like a few years for the kid to learn how to potty train, if we're thinking up to like preschool, kindergarten, like up to 5 years old, we're really hoping and wanting them to be potty trained because that's the expectation to go to school. That would be one area of impairment if we're noticing, ooh, this is causing an issue. And especially to your point about what if we're seeing multiple domains of impairment. So if it's like language development is also starting to lack, or um, I don't know, like other cognitive tasks, I'm not saying this is true for autism. I'm making this up, but like if you're noticing like motor coordination for some reason starts to decline, like walking, for example, and then all of a sudden they regress to like crawling again. I think that would be a good indicator that there's something happening that we should pay attention to, especially if you're noticing it in multiple domains. So yes, would it have more significance? I believe so, because I think that's to us, that tells us there's multiple domains or areas of functioning that could cause impairment or distress in the kid's life.
Okay, thank you.
Yeah, question. Okay, if no other questions, we'll continue. So this is where we're at in terms of it's no longer, so excuse me, schizophrenia is not under the neurodevelopmental disorders, under autism or intellectual disabilities. This is kind of its own section. And so we're only going to be covering schizophrenia because this is the one that has the clearest overlap with abnormal child psychology. And we will talk about this top one, schizotypal personality disorder, later on in the semester when we get to personality disorders. So hold that in your mind. But today, and just for the class, we're focusing on schizophrenia. So when we think about schizophrenia spectrum and psychotic disorders, it's kind of the broader category that we're thinking about. The way it's set up in the DSM, so this going back, this section right here that we looked at, it's moving in order of psychopathology. So it's not to say that like one's better or like better than the other. It just is talking about the severity of psychopathology that we're seeing. So a personality disorder, schizotypal personality disorder, would be considered less severe in terms of all areas of impairment and the level of impairment than, say, schizophrenia, and any of these other psychotic disorders. So just in terms of like the taxonomy system, that's how it's set up. Um, in other areas of the DSM, the way it's set up is not necessarily by level of severity. So it wouldn't necessarily look like this. Some of them are in order of age of onset. So we might see when we talk about the eating and feeding disorders, we're going to see feeding disorders first because that tends to appear earlier on in life. So things like ARFID, so avoidant restrictive food intake, that happens quite often in young kids. And so we'll see that presented first, and then you'll start to see other things like bulimia, anorexia, binge eating disorder. So that's how other areas of the DSM are set up, age of onset, and this is just level of severity. So why are we talking about schizophrenia? Because there are prevalence rates of schizophrenia occurring in youth. And although autism and schizophrenia in youth are distinct and separate disorders, they also share a rich history. And that's why we're talking about it today as part of the same topic. So for many years, childhood schizophrenia was applied to a heterogeneous group of children with certain impairments. So heterogeneous means multiple flavors, right, within a group. And so this term childhood schizophrenia many years ago would have encaptured children with intellectual disabilities or autism. And thinking back to like decades and years ago. So like that far back, they would have considered autism or any sort of intellectual impairment, having Down syndrome, things like that, as childhood schizophrenia. We obviously know that that's not the case, and so research has caught up. We've amended the DSM multiple times since then, and so now we have an intellectual disabilities section, and we also know autism is separate as well. So this terminology, schizophrenia, is just really, it's dated, and the reason it has any sort of significance here is because that was a term that was used to describe childhood psychopathology. And if we think back to week one, when we were reading about like what were the different historical movements of child psychology, we know that child psychology was a much later area of interest for people. We talked only or primarily about adult psychopathology. There were different like etiologies. We thought there were like spiritual things, there were biological mechanisms that were at play, and then we finally got to more of a psychological CBT sort of movement. So given that that was kind of the arc of how we saw adult psychopathology emerging, when we saw child stuff happening at the time that there was more interest in adult stuff, that was kind of attributed to schizophrenia. And again, the schizophrenia term that was used back then is not necessarily schizophrenia today, where we're talking about specific diagnostic criteria to explain the presentation of someone with schizophrenia. So essential features of schizophrenia do hold across age, but they might look a little bit different, and we're going to talk about that in the next few slides. But again, just history-wise, there's some history linking autism, intellectual disabilities, all of that with schizophrenia, and just because we didn't have a lot of terminology back then, and there was very few researchers or clinicians interested in children with psychopathology in the 1800s, early 1900s. So what does it look like when we're saying schizophrenia in youth? It is a super low prevalence rate, so it's not very common to see this in an outpatient setting. If you're going to see it, you're going to see it most likely in an inpatient setting where people have been hospitalized, if they're getting treatment. So when we do see schizophrenia onset in childhood or adolescence, we know that there must be a failure to reach expected levels of interpersonal, academic, or occupational achievement. So this sounds similar to some of our other disorders we've talked about. We're expecting that certain things are supposed to progress a specific way, whether it's speech or motor skills or what have you. And so here we're saying there is a failure across the board in all of these different domains given the child's age. So if we're going to specify that someone has childhood onset schizophrenia, that onset usually occurs before age 13. And then if we're going to specify adolescent schizophrenia, again, there's not a particular age. I think the that the textbook puts. But just in terms of the presentation, we think it looks a lot like adult onset schizophrenia. So childhood is going to look different than adult schizophrenia, but adolescent schizophrenia starts to really look like and mirror adult schizophrenia. Diagnosis in youth is reasonably reliable, and again, especially in inpatient psychiatric settings. So it's pretty uncommon, given, let's say you need treatment. This is pretty impairing to have schizophrenia, and so you're not going to see it most likely in private practice or an outpatient setting where the acuity is quite low. So usually you end up in a more intensive hospital setting, so inpatient psychiatric setting, because of the level of care that needs to go into managing these problems. And again, diagnosis prior to age 13 is relatively rare, but diagnosis in youth across the board is pretty reliable. And as always, but especially in schizophrenia, the symptoms must be distinguished from typical development and in the context of their developmental level. So we really, really, really want to be careful and want to make sure we're paying attention to developmental progressions, what's to be expected given their age, and that we can say that this truly deviates from that and it meets a set of criteria. So these are the diagnostic criteria for schizophrenia as a whole. Schizophrenia doesn't have, I don't think, anything specific to childhood, except for criterion F down here, and we'll talk a little bit about it. So criterion A, 2 or more of the following, and at least one of those 2 or more needs to be number 1, 2, or 3 right here. So you must have 2 or more of the following of delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. And negative symptoms can look like kind of flat affect, avolition, diminished emotional expression. So that's like that restriction and range, like flat affect. So just with criterion A alone, we need to see at least 2 of them, if not more. And one of those needs to be either a delusion, hallucination, or disorganized speech. Criterion B is what we expect, though it needs to impact major areas of functioning, and needs to be markedly below the level of achievement prior to onset. There need to be continuous signs for at least 6 months, should not be explained by 3 set of disorders, according to criterion D, same thing with E. We need to rule out some other medical condition. And then criterion F, if there's a history of autism or another communication disorder where there's childhood onset, then if we're adding a diagnosis of schizophrenia, it's only because we are seeing prominent delusions or hallucinations that have been present for at least 1 month. So this one is saying, like, if there is this history of autism or something else, if you're going to add on this label of schizophrenia, it needs to be unique in that it's contributing and saying that it's also this delusion and hallucinations that we're seeing. And we're seeing these other diagnostic criteria. Okay, so this criterion A, 1 through 4, is it 1, 2, 2? Yeah, 1, 2, 3, 4. 1 through 4, we would consider those positive symptoms. And the negative symptoms, going back, we gave some examples of avolition, diminished emotional expression, which is like restricted affect. That would be considered a negative symptom. So we hold these 2 things in mind, and we call these positive symptoms and we call these negative symptoms. And right now we're kind of parsing them apart because childhood schizophrenia looks a little bit different in terms of whether or not we see positive or negative symptoms. So positive, negative doesn't mean good or bad. Just remember thinking back to when we talked about reinforcement and consequences in terms of behaviorism. Again, positive, negative didn't mean bad. In that sense, positive meant adding something and negative meant taking away something. In this situation, positive symptoms indicates distortions or excess in normal functioning. So I kind of think of it as additive also, in that there's some sort of distortion or change in thinking or something that adds to it that's in excess. Negative symptoms indicate a lack of normally occurring behavior. So it still is kind of that negative, like taking away, like we're reducing affect. We're reducing will to like walk through life, things like that. So keep that in your mind because they're a little bit different in terms of what we see most often for kids versus adults. Okay. So just talking about what are some quickly, what are examples of all these little things? So positive symptoms. Delusions are different from hallucinations, which are different from disorganized speech, which is different from catatonic behavior. So delusions have to do with beliefs. And so they're erroneous beliefs. They're beliefs that are really bizarre, out of the norm, and are not rooted in reality. So examples of delusions might be persecutory. So something like um, the government is out to get me, or like I am watching TV and well, okay, let me use that example for later. But persecutory is I'm in persecution. People are out to get me. Somatic is again having to do with the body. So maybe having beliefs about like, I don't know, like my arm is a portal to blah blah blah, something like that. So that's a erroneous belief that having to do with the body. Bizarre is just another adjective to explain that it's not rooted in reality. And then grandiose is these large, really larger than life, centering yourself in the middle of the beliefs. So the example I was going to give with the TV would be like, I just watched, I don't know, I just watched this show and that show was speaking to me. It was about me. Everyone knows it's about me and that show is out to get me or something like that. So really finding yourself in all of these different things. And again, it's erroneous because it's not rooted in reality. It's different if you are, I don't know, like a celebrity and you did get talked about in a television show or in the news. That's different, right? Because that's rooted in reality, that's rooted in truth. There is a segment on you versus that thing that that person said, like on this show, like like anime or something, right? Like that thing that has nothing to do with that person. They find a more what they believe to be a morsel of truth in there, and then run with it and feel that that's truth to them. So again, delusions are about your beliefs. What are you thinking? Hallucinations have to do with your perceptions, and with this, think about your five senses. So you can have auditory hallucinations, so you can hear something that isn't there, or you can see things that are not there. So an auditory hallucination could be, I hear people talking to me. And again, this is considering culture and age. So in terms of culture, it's not to say like, oh, I'm religious, I believe in so and so spiritual figure, and I sometimes hear, that person uplifting me. That's not what we're talking about. This is like consistent. So it could be religious in that maybe it's all the time this person is speaking to them, and it's causing impairment or it's really causing some negative functioning, so impairment, or it is like I hear so and so in my ear talking to me. So delusions and hallucinations on TV tends to be the thing that we see portrayed the most. So whenever you see like, I don't know, like crime shows and you see somebody like he's talking to me right now and you hear things like persecution or like beliefs to go do something according to this voice that they heard, that's getting into the delusions and hallucinations. And that's what the command thing is. Sometimes they might hear a voice commanding them to do something. Auditory would be so that's what I just talked about. Sorry. Visual would be I see something. So I see a figure. I see blah 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 right in front of me. I see a bunch of people. I see whatever it is. And again, it's not there. This is different than like, oh, I thought I saw something at the corner of my eye. Sometimes that happens. Like I always see the example of people saying like I have a room in my chair that like I put all my laundry in. Like that's my laundry chair. And at night, sometimes I look over and oh my gosh, there's like a big figure. That's different, right? Like that's a quick like, oh, I thought that was something there versus I see it, it's stable, it follows me, or every time I'm in that setting, I see it. So that's different. Same thing with the auditory. Sometimes you might say like, oh, I heard something. I thought I heard someone say that. That could be a one-off, right? That's different than I'm hearing something and it's consistent and it's really impairing. Disorganized speech. So that's distortions in the way that we talk. We think a lot of like word salad, so things just not making sense. It doesn't flow. It's just they lose you as soon as they start speaking. That's the disorganized speech. So it's thought that's getting all garbled, and then in the presentation, the way that it's being spoken also reflects that distorted thinking. So that then means that there's some sort of difficulty organizing their speech and like making a cohesive narrative story. And even though they might be saying a lot of words, it has really little meaning. So if you're actually trying to pinpoint, okay, what are they saying? Can I follow? Even if you are trying to follow, whatever that is that they're trying to say has pretty little meaning in terms of like it's unclear what they were trying to say. And then grossly disorganized or catatonic behavior has to do with behavior. What are they doing? And so it might be really like, in terms of catatonic, I'm going to talk about that one first. So that's motor disturbances. You might see some like strange body postures, like the way that they're like moving could be really distorted or kind of like it's like a tilt or things like that. So something odd happening with their bodily presentation. And then the disorganized behavior could be like, for example, like laughing all of a sudden or not taking care of their self grooming, things like that, or being really agitated or aggressive, seemingly for no reason given the context. So this is what we think of as positive symptoms. Remember that that's adding, something is in excess, there's distortions being added here. And so that's across the board when we're talking about schizophrenia. And when we're talking about youth schizophrenia in particular, we tend to see more positive symptoms. So there's more emphasis on these sort of behaviors versus negative symptoms, which have to do with, again, restriction and affect, restriction and speech. So kind of like pulling things back in. So little emotion, brief speech. So like very little speaking would be this, what we're talking about here, versus positive, which is like word salad, like talking like they're on a motor, things like that. And then this last bullet point, no initiation or maintenance of goal-directed actions. So these are negative symptoms. And with kids, it's not that we never see it, it's just that we tend to see more of these positive symptoms if there is going to be a schizophrenia diagnosis. I'm not going to cover the etiology, but it's in your textbook. I gave you a history in terms of there used to be shared terminology to explain things that were not actually schizophrenia, and really back then might have been autism or some other intellectual disability. So there's a rich history in terms of the shared history of both, and then there's going to be some shared genetic risk factors for ASD and schizophrenia, which is also why there was some linking back then. But they are not one and the same, they're different. But as with most things, there are certain areas of the brain or a specific gene that seems to be implicated in certain disorders more than most. So I would recommend you all read that. And I can tell you in terms of the exam at the end, like how much of that is going to be on the exam. But I do think it's helpful to know like that there was a history in terms of abnormal child psychology, but even then they're different. And we really didn't have that many slides on schizophrenia. So this is a really interesting documentary. There's also a book on it. I don't have it with me, but I have this book that I borrowed from a friend. And I think this is really interesting because it's an example of like the genetic heritability of schizophrenia. So schizophrenia has very, very high heritability rates. So again, we always think about environment and your neurobiology and all that stuff, all those things as being etiological risk factors and how those things interact with one another to then kind of prompt whatever the manifestation of any sort of disorder is. But with schizophrenia in particular, we really like that gene aspect is really, really weighed heavily because of that heritability. So having a family member with schizophrenia means that you have higher risk, not you personally, but your family, like in relation to that person, would have higher genetic risk factors there. So again, if we're going to fill out a history form, you're going to go to the therapist, you're going to go do an assessment. When you're filling out that record form and you say like family medical history, no. Family psychiatric history, yes. Brother with schizophrenia, that stuff is also taken into account. So I say all that because this video is about 6 brothers out of a family of, I think that's all, it's either 7 siblings or 8 siblings total, and 6 of them have schizophrenia. And this book details one of the siblings without schizophrenia, what her perspective was living with her brothers and noticing like when the onset of schizophrenia occurred for each one of those siblings. And I think I want to say the mom also had schizophrenia, something like that. But a super interesting, sad story. So there's a YouTube documentary on it, and then there's also a book if you're interested. I just think it's really interesting. It's just there's nothing on the exam on this, but are any of you guys familiar with this? Have you heard of this Six Brothers?
No.
No? Okay. Yeah, if you find any interest, I think it's a good watch. And I also think in terms of how this relates to our class, these are kids where there was childhood onset. And so I think it's fascinating that it's like the genetic risk and then the environment that the child grew up in also exacerbated the onset of schizophrenia. So, okay, there's that one. I think we have like 2 more slides on this. So developmental course, what can we expect over time with the symptoms of schizophrenia, having schizophrenia? So childhood onset is likely to be gradual and kind of get worse over time. So it's pretty alarming to have childhood onset schizophrenia, not versus adult, but like the time living with schizophrenia is starts earlier and the severity kind of like is gradual and but increases over time. So childhood onset, only 5% of cases are acute. Delusions tend to look different than adult delusions. So they're likely to be simple when they first appear. And then over time, they tend to get more elaborate. So small things like, oh, I don't know, maybe my teacher believes this about me or something like that. Something that feels benign, but then gets more elaborate, more detailed, and becomes very clear that like, ooh, it's getting worse. Same thing with hallucinations. They usually start off simple. So it could be, oh, I heard my toy saying something, or my animal saying something, or like believing in monsters and seeing a monster. And so you have to really be careful about, is this like a normative bedtime fear where like sometimes they're afraid of monsters, hypothetically, like under the bed or in the dark? Or is it like this kind of persistent belief about monsters? So again, the presence right away is not necessarily a telltale sign in childhood, but looking at if that's coupled with any of these other things is also an indication that there's something different about this hallucination. And also, you can tell if it's a hallucination versus like a childhood fear. So again, likely to be simple at first and then kind of grow more elaborate. Negative symptoms are unlikely in children. We kind of touched on that already. So restricted affect and then no goal-directed behavior. We tend to not really see that in kids. There are different phases of the developmental course. So typically we have the prodromal, the acute, the recuperative/recovery, and the residual phase. So prodromal means like, and this is not just schizophrenia, but well, you hear this term primarily with schizophrenia, but prodromal means it's like right beneath the surface. Like you're not quite at the threshold of meeting criteria for schizophrenia. So you're seeing the stuff there. It's like right at the surface. You're right about the diagnostic cut off, but you haven't quite gotten a diagnosis of schizophrenia. So we typically see prodromal, and then the acute is you have it, it's full-fledged, it's really in action. This recovery is like with sort of treatment in place, and then the residual is kind of like whatever's left over. But it is a chronic thing that we're always going to try to treat over time. So that's different in terms of the developmental course than adolescence. So that one tends to be like less gradual. And again, this one looks most closely like adult schizophrenia. So what we mean by that is that there's considerable variation in terms of the timing, the severity, and the nature of the early features. So if it's not childhood onset, it might just appear at this time or this time for somebody else. So all of that is going to vary in terms of when it appears, how severe it is, and then what did those early features look like? Was it a delusion of persecution versus delusion of grandeur? Like things like that are going to look different. And then with this, it is common to see negative symptoms just as you would see in adults. So that's why it's similar to adult schizophrenia. The earlier the onset, the poorer outcomes that it's associated with. And I think that makes sense. The longer that you're living with these like cognitive impairments, so it's just early onset tends to be associated with poorer outcomes. And then child and adolescent schizophrenia carry a higher than usual risk for premature death. And you can read your textbook about why that is. This is, again, you don't have to read this. I put it in here like I did the PMT chapter that we looked at. So PMT, I plugged in like a webinar that I liked, and it was like an hour long, so you don't have to watch it. But if you're interested, those were the components of PMT. Same thing here. I think this is an interesting talk at a conference about exactly what we were saying with the genetic risk factors and what's shared between autism and schizophrenia, and then like how treatment differs because of the differences in the disorders, but why you might have some genetic, like the genetic links, which makes the topic linked in one and it linked together. So I plugged this. You don't have to watch it. I watched it. If you're interested, go for it. Okay, so looking at time, I figured we would get through this. So your task for this week is finish the reading. I specifically put like pages that I wasn't covering that you can skim, and then start reviewing for the exam on Monday. So that means we have chapters 9 through 13. So those are all the textbook chapters. And we also did the guest lecture with Shira. And so some of the questions have questions on there that Shira would have covered in some sort of way in her lecture if you attended. So I'm going to stop sharing this for a second. And I will take a poll. So what do you all want to do? We can end because we finished the chapter, and we can save Friday as our usual exam review day. We can start the exam review and see how far we get. What is everyone's preference? And also just to add, I think if we finish the exam review today, I think maybe it's not fair to people who are planning to come on Friday. I can leave my the link open on Friday if people don't come today. We do the exam review, so that way they can ask questions. But today would be like primarily the exam review since you're all here. Okay, I see someone say start the review. Other preferences? Okay. All right. In the absence of any challenges to that, I will start it, and then I can do it again on Friday for people who are not here. Okay, so I'm not sharing anything. So write down all of this if you can. So just some logistics again. It's open on Monday, closes on Monday. So it opens at 12 a.m., closes at 11:59 and 000 seconds p.m. Same structure as exam one. So it's 50 multiple choice questions. So it's going to be worth 100 points. And then, yeah, you also have 90 minutes to complete it. So once you start it, you have to finish it. So do it in one sitting. You have 90 minutes to do it. Okay, those are the logistics. And also on Monday, that means we don't have class because you're taking the exam. So I won't be on the link, but I can try to be monitoring my Canvas inbox if there are any issues. Because if you run into issues, tell me right away so I can try to help. Same thing with Ariel. If you contact her, do it right away. In terms of, okay, this question will also be in order from, okay, so the question is asking about the order of the exam. It's generally in terms of the topic material, so not necessarily in chronological order. So it starts with, yeah, it's the way that the order in which we learned it. So we started off with ADHD, and then we kicked off with Shira's lecture before I started teaching the oppositional defiant problems section. So things like conduct, intermittent explosive disorder, barely, we didn't really cover that. But conduct and ODD were the two that we really talked about. So ADHD, guest lecture, ODD, conduct, things like that. PMT is somewhere in there because that's the treatment for both of those types of disorders. And then we covered communication disorders, I think. Yeah, communication, specific learning disability, intellectual disability, and then this week, autism and schizophrenia. So I think that's the order in which we taught it. So that's the order that it should come up in the exam. Okay. So that's the structure. Looking at ADHD, we have I would say like 10 or so questions on ADHD, give or take. And it's different things that I covered in the lecture. So knowing what's normative, like what do we expect for kids at when they're getting diagnosed with ADHD? Are there certain differences in the time of day that you might notice, like their behavior drop off or like the level of impulsivity gets worse or maybe slows down? We talked a lot about, so what I mean by normative was like we kind of talked about like some myths or some questions about like, is this true for ADHD or is this a myth or, is that false? So we talked about some of those kinds of things. And with that, a lot of myths about like being able to sustain your attention in one area versus another area. Is it the time of the day that matters? Um, is it something that's lifelong or can we treat it? Things like that. What are examples that might convey the differences between hyperactivity versus impulsivity versus distractibility? We also talked a lot about what are some of the risk factors of ADHD and then what are some of the associated outcomes. So, depending on age, we saw different things about like, are there motor coordination issues? Are there higher risk of accidents based on the age range, things like that. So, all the things that we covered in the ADHD slides when it comes to etiology, well, not etiology, but like the presentation, how it differs by age range, what to expect, what are some myths, and then what's the treatment for ADHD. So there is at least a couple of vignettes on the ADHD section, and vignettes are going to look similar to the last exam where it'll either ask you like what's the likely disorder or it'll say this person has this disorder and then you answer the question related to it. Okay, so that's ADHD and then about 10 or 11 again, give or take, of the ODD, oppositional defiant conduct questions, and that lumps in Shira's guest lecture as well. So pretty basic. This one has a lot of vignettes in there. So again, you're going to read something. It'll say, what do you think this person has? Most likely. It might ask you treatment or it might ask you like, is this a myth about conduct or ODD? Things like that. How do you treat it? Yeah. So mostly vignettes for these questions. And then we spent some time doing communication disorders and learning disorders. So we have okay, so there's probably like it feels pretty lumped together. So the specific learning disorders and the communication disorders, there's probably like 10 in that section itself. But remember some of the things that we talked about with learning disorders carried into our intellectual disability section. So we talked about IQ and the different models or approaches in the specific learning disorder world, and that still carried over into our conversations about intellectual disability, how we consider IQ in either of those disorders. So I would say like 10 questions, 12 questions, lumping together communication disorders and learning disorders, and things like, do you know the difference between expressive versus receptive language? We need to know that in order to be able to diagnose a communication disorder, we need to know where the impairment lies. So do you know the difference? Do you remember like articulation, speech sound articulation disorder versus general, I think it was developmental speech delay or something like that. So there were two particular language disorder, excuse me. So we talked about two specific communication disorders. We looked at some examples. So knowing what are examples of a speech sound disorder, knowing if I say there's an expressive language impairment and I gave you examples, like could you say, oh, that one's expressive, this one's receptive, things like that. We also talked about in the communication disorder section, social pragmatic communication disorder. So we talked about this is in the section. Here's how this differs from autism. So that's going to be on there. Yeah, some more questions about expressive versus receptive. Questions about developmental course for language difficulties. So we talked a lot about like there's some normative timetables that we care about with the development of language. And we talked a little bit on the slides about when there's a certain age that they hit, outcomes, like worse outcomes are associated with this age versus a later age or things like that. So that's on the developmental course slide. If you attended lecture or if you watched the video, there's a question on there about what did we see in one of the videos, again, related to communication disorders. And then learning disorders will ask you about, we talked about different terminology. So if you're in the medical or psychological community, is there a difference between when we're talking about education and more legal terms to describe the same thing? So we talked about that. We also talked about the different types of specific learning disorders. So there's the 3 R's, there's arithmetic, so math, writing, and reading. So knowing the difference between the different types of learning disorders, given the particular impairment that you're seeing. When it comes to reading, so knowing, or sorry, not just reading, but reading, writing, or math. Like if I gave you a picture from the book, it's literally in the book, and I asked you, what is this an example of? Is it an impairment in reading, writing, math? Could you tell me what it is? The hint there is open your textbook. It's in there. Also, so we talked about the 3 R's of specific learning disorder, and then for each one of them, we make some distinctions between word level versus text level. I think there's like the reading level one versus like a different one. So there were distinctions for each impairment. And so knowing what those are based on the specific writing impairment, reading impairment, math impairment, know what those are. And then at the end of our specific learning disabilities, learning disorders chapter, that's when I started putting in, like, we're not covering this in lecture, but I advise that you read it. So there are a few questions on that if you read it. So things like, what is the approach to learning disorders that is being used? What are the differences in approaches? So like the traditional approach versus the response to intervention approach. How are those different? Are they, and what constitutes the response to intervention approach? So what does it do? What is it for? What can you expect in an RTI approach? I didn't really cover this, and it's in your textbook, which is why I'm saying there's a slide where I said refer to your textbook. What does the IDEA, so remember that act for special education, what does that mandate? What do you get? What is the point of it? What do you get under that act? There's one question on that. Okay, then we start getting into intelligence, which again, like it's kind of like a segue between specific learning disorder and intelligence. So we talked about IQ, like, do you know the testing that we do? So I showed you guys like a picture of the WAIS, or actually I showed you the WASI, which is an example of a Wechsler intelligence test. So the WASI is like a short form version of the WAIS, and that type of test typically has a specific number that they keep in mind. So if you're above or below in terms of standard deviation, this number, that usually signals to us that there's some sort of intelligence impairment going on. So do you know what the standard number is that we use? What's that? Is it a standard score? Is it a raw score? Things like that. So there's a section in your textbook and in the slides where it literally tells you, here's what we expect with intelligence testing. Things about, and this came up with autism, but again, especially at the end of intellectual disability section slides, what's the difference between adaptive behavior and intelligence? Or do we weigh them equally? Are they exactly the same measure? What's the difference? Why do we care about one or the other or both? Yeah, another RTI question. This is in your slide. I'm going to give it to you. There's one in your slide that I didn't like verbally say, but it's on there. There are different effects when it comes to intelligence testing. So there's things like the Matthew effect, the Flynn effect. So one of these questions is asking, like, do you know what one of the effects is? If I were to tell you, here's the trend that happens, which effect is it? So there's a slide on Matthew effect and there's a slide on Flynn effect. So just read it and make sure you know which one's which. Yeah, so I said RTI has another question, and then, okay, and then getting into genetic causes of intellectual disability, there's literally, I told you this in the lecture, there's only one question on intellectual disabilities in terms of genetic causes. Do you know what they are? That's what the question's asking. Okay, and then the rest is going to be, so this is like the last 10 questions is autism heavy. So we covered 9, 10, 11, 12, 5 chapters, and one of those chapters was pretty like combined into one. And so it's pretty evenly spread out in terms of the 50 questions. It's fairly 10, 10, 10, 10. So pretty equal weight. So for autism, we talked a lot about like what were the shifts in terminology in terms of the DSM. So did we collapse terms, or did we keep it broader? Like things like that. Is it the same terminology we used in DSM-4 versus DSM-5? We talked a lot about well, not a lot, but there are a few slides on myths. So there's some stuff that's been out there about the causes of autism. There are different things that have been said and that have been debunked. So were you following along? Do you know what the risk factors are in terms of evidence? And do you know which ones to debunk if I were to say, here are some potential causes of autism. Are these true? I mentioned this earlier with the communication disorders. What's the difference between autism and social communication disorder? If I gave you an example, and it's kind of like the vignette we looked at, if I gave you an example of a type of behavior, could you say, oh yeah, that's definitely an indicator of a social communication or a repetitive behavior, RRB that I'm seeing here? Does it change based on age? So if I'm like, we talked about infants, how like the gaze they might not do joint attention in terms of gazing, they may not follow your gaze, they may not respond to their name. So we talked about different indicators throughout youth that usually gets the child to some sort of assessment treatment standpoint. Okay, yeah, another one about debunking or confirming whether or not this risk factor for autism is true. We talked a little bit about treatment, so there's just one question on treatment of autism. And then the last 3 questions is what we covered today. So 3 to 4 questions on schizophrenia. So do you know the difference between a hallucination versus delusion versus the other symptoms? What's the difference between childhood onset versus adult/adolescent? Does it matter if you're diagnosed at childhood versus adulthood? And that's it. So that's basically all the questions. There's of course going to be like, if I gave a secret code word during any of the lectures, there's a question on that. if you watch the video, there's some things we did together, so that's on there. And then if you went to Shira's lecture, you probably have a higher chance of being able to answer the question than if you didn't. And that's all 50. Any questions? Okay. I'm looking at the time. I'm curious what you all think. Okay, this took like 15 minutes, if that, maybe 20 to go over the exam review. I'm realizing that we're still recording. I might just cancel Friday, and just have people watch this review, unless any of you are planning to come on Friday to class. If you were planning to, you let me know. Otherwise, I will just post this recording and people don't have to come to the exam review. Yeah, so that question, will we still go over? There's really nothing else. I just finished all of it. So I would literally be repeating what I just said on Friday. So that feels not necessary to re-say the same exact thing, especially if you're already here, like, and you're planning to come on Friday, you don't have to because I'm not covering anything differently. Yeah, thank you. Okay, video should be fine. I will, if you want to let your peers know, if you talk to them, I'll just cancel Friday and I'll post this recording and I can point them to the last 15 minutes of the recording. That way, yeah, they can watch it during their time. Okay, thanks for your input. I will do that. I changed my office hour because I couldn't attend Monday. If you want to attend office hours, I will be there on Friday after, so 10 to 11, but otherwise I won't see you all till Wednesday because you'll have class Monday, or sorry, you'll have your exam Monday, and then we'll meet up on Wednesday of next week. So I'll see you a week from today. Okay. Good luck on the exam. You guys will do great. See you all next week.